given the opportunity to present the BEST3 trial from a nurse's perspective. Can I start again?
Yeah, of course, just start again.
Yeah. I'm delighted to be given the opportunity to present the BEST3 trial from a nurse's perspective. A study of such magnitude would not be a success without the commitment of the whole team, but in particular, the nurses and their contribution on the front line as delivery of the device and the study at GP practices. I'm Irene Debiram-Beecham, and my role involved being the lead nurse and clinical coordinator for the BEST3 trial. My contribution was to ensure that all GP practices and the intervention, I'll do that again. I'm Irene Debiram-Beecham, and my role involved in being the lead nurse and clinical coordinator for the BEST3 trial. As lead nurse, I needed to ensure that all the GP practices and the intervention sites had nurses, and the nurses and relevant team members were trained and ready to recruit and administer the cytosponge. I provided guidance for GPs and feedback of results to patients, and liaised with the endoscopists at secondary care sites through relevant channels in order to book patients who had a positive finding on their cytosponge test. I will give you a brief outline of nurses' involvement, but before I do this, please let me take the opportunity to introduce you to some of our nurses who were key in making sure that this study went ahead at all the different GP practices. I'd first like to introduce you to Siobhan Campbell, who was one of our nurses at the Eastern CRN. Siobhan.
Hi, so my name's Siobhan Campbell, and I am a research nurse in primary care based around the Cambridge and Peterborough area, and I worked on the BEST3 study between 2019 and 2020, and I really loved taking part in that.
I'd also like to introduce you to Marie Corcoran, who was also one of the CRN Eastern nurses.
Hi, my name is Marie Corcoran, again, research nurse based in Cambridge and Peterborough. So I worked alongside Siobhan on the BEST3 study between 2019 and 2020. So yeah, it was a joy to be part of.
I'll introduce you to Lydia Owen, who was one of the nurses at the, one of our nurses at the Oxford, as part of the Oxford team.
Hi there, my name is Lydia Owen. Yeah, as Irene said, I am a primary care research nurse. I work in the Oxfordshire area in the Thames Valley South Midlands CRN. I was part of a team of 3 nurses that worked on BEST3 in and around the Oxford area. And I have to say it was one of my favourite studies to work on.
And next, I'll introduce you to Jill Ducker, who was part of the team at North Eastern Cumbria.
Hello, yes, my name is Jill Ducker. I'm a primary care research nurse, and as Irene said, I was involved in the BEST3 study in the northeast of England. And to echo what the other girls have said, I loved working on the study. I really enjoyed it.
I'd like to also introduce you to Nikki Todd, who was also one of the nurses at Northeast and Cumbria.
Yeah, my name is Nikki Todd. I'm one of the primary care research nurses. Again, I worked alongside Jill Ducker at North East and North Cumbria. And again, I would say it was a really good study to work on and felt really supported by the study team.
Great. Following the introductions, I'd like to just give you a brief presentation on what the study entailed for us as nurses and to share the nurses' perspective on the BEST3 trial. I'll just share my screen. Can you see that?
No, nothing yet, Irene.
Okay, hold on a minute. Right, can you see that now?
Yeah, now we've got you.
Brilliant. So the presentation, as I said, would consist of the nurse's perspective on the BEST3 trial. The cytosponge device is a simple but easy to use tool that can make a big difference to a patient who has been on long-term acid suppressant and has suffered with acid reflux for a long time. The study was a cluster randomized plus a patient-level randomized control trial, and this was carried out across various GP practices. At the time when this study was presented to us, it seemed easy enough. And when we looked at the protocol and tried to decide what it actually meant, it seemed that we could potentially do this practically. But we had very limited resources at the time and very limited time, and therefore we needed to put a strategy into place in order to implement and recruit 109 GP practices and potentially about 13,500 participants. So a study of such immensity, when presented to a team, the first thing that springs to mind is, what do we need to put into place? And one of the key things of making this work is extensive planning, having good communication between teams, and offering your time when needed, and of course, being dedicated and a strong desire to succeed. We also needed to maximize resources where needed, and to troubleshoot well ahead to ensure that there was no delays in delivery of this study. So this recruitment strategy. So one of the key things we needed to do first was to ensure that we had a secondary care site identified. And with that in mind, then we would approach the CRN team to identify GP practices within that region that could potentially feed into the secondary care sites. Because one of the key things that we had to bear in mind, but that if a patient had a positive finding, then we needed to provide that patient with an endoscopy in order to explore why they had a positive finding. So once these primary care sites were identified, then they would be sent out the research information sheet, which they would then fill in to express their interests in the study. Once that was completed, then the CRN team would help us to send out the feasibility questionnaires where the GP practices would then complete to see whether they had capacity and capability to carry out the study at that particular practice. Once all this information was received, the sites were then assessed to see whether for the amount of patients that they could pull off their searches. And then, of course, site initiation visits were set up, and the study teams were taken through the process that was required for the BEST3 trial. So just to give you an idea of the different sites that took part in the trial, the 109 GP practices stemmed across from northeast Cumbria all the way down to Plymouth or Southwest Peninsula. And we had a number of nurses across all these different sites. Some sites, for instance, Peninsula had one nurse, whereas, for instance, Wessex had a team of about 7 nurses that took part. CRN Eastern in total had about 10 CRN nurses and 10 practice nurses who were also involved in the study at their particular site. As you can see, most of these sites were down the eastern corridor of the country, and I think it just seemed to happen that way. That wasn't our intention, but it seemed that most of the GP practices that express interest were along this corridor. So one of the things that we had to put into place was, once a site was activated, what we do is allocate that site a code. So therefore we can identify them ahead of time. And also to make sure that that we could also identify samples that were collected from that area, and therefore all data was stored under that site code. The searches were then carried out at the practice, and the number of patients were then established as for that GP practice as to what they could potentially recruit. All contracts were put into place, and then a site initiation visit was carried out where we would ensure that GCP and CVs were collected for each individual who were part of the study team at that practice. A start date for the study was agreed, and then MHRA had to be informed. And once all these processes were carried out, then of course we then had our first opt-out letter sent via doc mail. So during this time, we also had to identify which nurses were potentially going to carry out these clinics at those GP practices, so that we could align the cytosponge training ahead of time and prior to them starting their clinics. So groups of 2 to 10 nurses were put together so that we could carry out the training, and this just made sense, probably doing it in a central location. So one of the key areas we used was Cambridge, and some of the nurses would travel to Cambridge, where we would do a combination of video, PowerPoint presentation, and then live clinical procedures. And I think the nurses benefited from this and felt that once they knew what the procedure was all about, and they can see the follow-through process, that it would be much better for them to, well, can I do that again? They felt that they could then run their clinics independently at the GP practice. They were then given the cytosponge SOP to have a look at before any clinics were established at the sites. And part of this SOP emphasized the emergency procedures that were needed and any adverse events that they might encounter. They were assessed by the trainer for safety and delivery of the device, and also withdrawal of the device. Once signed off, they were able to carry out clinics independently and with ongoing monitoring by the trials unit. For all the sites across the UK, all GP practices, once the cytosponge invitation was sent out, following the opt-out letter, those responses came back to Cambridge, apart from one site, and that was the Northeast. The Northeast seemed to do all the screening for their patients and send out their appointments and book them at their GP practices. The rest of the sites around the UK, their responses came centrally to Cambridge, and we had ethics approval to see these patients' identifiable data. These patients were then contacted, and then they were screened for their eligibility for the trial. Appointments were then booked, and then the list of these patients were then sent to the GP practice, where the appointment letter, confirmation of the appointment, was sent out to the patient. Following on, sorry, I can't see that. Following on from the training, we then set up the clinics, and the nurses were able to feed back to us whether there were any, sorry, I start again. Following on from the clinic, the nurses were able to feed back what level of support they would need after, let's do that again. When nurses were not able to make the group training, we did one-to-one training at the GP practices, and these nurses were supported over a session of 2 to 3 clinics until they met their competency. Feedback of the training was overall positive, and I will share that with you in my other slide. With regards to results, these were forwarded to the GP, and in correspondence with the clinical coordinator, advice was given to the GP as to which clinical feedback letter was appropriate for each result. These were dealt with in a timely manner, making sure that patients got their results, and the follow-up plan was in keeping with between 2 to 4 weeks following them having the test. Positive results were then identified, and the endoscopies were booked at the relevant secondary care site. The recruitment phase was quite intense, but we allowed 3 months in order to complete a site before that nurse would move on to the next GP practice. Some of the feedback we had from various nurses was that the content of the training was well organized. They had a very informative, very pleasant day. They thought the training was excellent. They enjoyed learning about a new skill, about learning, getting more information about the whole experience, endoscopy experience as well for them, because some of those nurses had not seen an endoscopy. So part of the training was doing the cytosponge within our unit, but following that through and seeing for them to see a patient undergoing an endoscopy. So that kind of highlighted the outcome of what could potentially be the outcome for a patient who had a positive result. As a result of the training, and as a result of the BEST3 trial, we thought in order to kind of move things forward, that a advice and handy tips document would be a very good thing to have for future training of nurses who are going to carry out nurse-led clinics for nurse-led cytosponge clinics. So some of the key things we included on the advice and handy tips document was things like inspecting the device, advice on how to bunch the string in different ways, sort of swallowing techniques, what techniques to use if you had a patient that was very anxious. How many times would you use a cytosponge if it was placed in a patient's mouth? Because sometimes you would think, oh, well, they only put it in their mouth, but some people weren't quite sure whether they could reuse that again. So we've put together a document where we've emphasized some of these sort of questions that nurses might have. They also wanted to know, what would you want? We also wanted advice to be given or be available for nurses on if a patient had continued sort of gagging throughout the whole procedure. What could you do to sort of minimize this? And also, what were the key things on retrieval? What is the key things you would ensure you were doing when retrieving that cytosponge? So we put together this thinking that when these sort of nurse-led clinics are rolled out, that they've got an advice and a advice document they can always refer to when running their clinics independently. So I just wanted to highlight, because as the coordinator, I had various responsibilities, and some of these overlapped with the project manager, but most of the time we tried to keep our role fairly separate, but there were instances when we had to overlap. And it was very fortunate that I had the opportunity to work with Beth Muldrew, who was the project manager at the time. And we had great support from the chief investigator, who is Rebecca Fitzgerald. She was very supportive and engaged, and would help us overcome a lot of the barriers that we faced during liaison with different sites, etc. So one of some of the things I had to deal with and was part of my responsibilities was together with the project manager, we were liaising with different CRN sites and arranging initiation visits. Also organizing the training. When you're trying to organize training for such a wide group of individuals, it becomes quite tricky, and you can't offer one-to-one training for each individual. So we had to make a decision as to when group training was appropriate and when we needed to do one-to-one training. So that was key to making this the training aspect of it a success. We also wanted to make sure that reimbursement. So one of the things I had to make sure with our finance admin was to make sure reimbursement happened in a timely manner, and there wasn't a delay with sites getting reimbursed, especially when they had finished recruitment at their site. Also liaising with GPs about results, which I previously said, and in order to engage with the different sites and getting various GP practices on board, we had to do a lot of public engagement, presenting at GP forums and CRN events, which then emphasized some of the key things about the study, but also raised interest to other GP practices as a potential study they could take on board. I also managed a small team of nurses and administrators, and of course was part of the cytosponge screening team at our Cambridge hub. We supported nurses with clinics, and part of my role was to offer a 24-hour online support, as 24-hour on-call support for the patients as well as the clinical team. So along with everything, the study was quite immense. There was a lot happening, on a day-to-day basis. And of course, with a study of such magnitude comes its highs and its lows. And one of the things that was much more eminent in this trial was the immense amount of time I spent on the road, and the nurses, the CRN nurses, because they had to travel from practice to practice to see their patients. So it was a lot of effort. We also had to see patients during that unforgettable snowstorm back in, I think, was it 2018, the Beast from the East. And you can see the photos on the side. That was me dragging my case up the hill in Durham, trying to catch a train back to Cambridge. So, you know, so we encountered a lot of different things, such as, you know, we had the weather against us at one point. You know, we had, you know, to get over various sort of administrative barriers, etc. But, you know, with the low comes the high. We built great contacts and networks of nurses. We built relationship with different teams, which mean that we could do future collaboration. And I think that really negates the lows for me and for some of my colleagues. Lots of nights away from home, but that also meant we could progress the study. It meant that being on site, we could troubleshoot things ahead of time. It also meant we could give the nurses and the team support where needed. And this also helped them to be more engaged and committed to completing the study. Yes, there was a 24-hour on call, but the teams and the patients were so respectful of my time that they really didn't take advantage of that and only phoned when they absolutely needed assistance. The low side for some of the nurses were, from the training aspect, was that where we trained nurses up and then they left before they were either signed off or they had a chance to complete recruitment at that site. And therefore it meant we had to retrain some of the nurses. But it also meant that the majority of nurses across all the different practices were committed, and they worked at a very high level and made sure recruitment was completed on time. We had some diagnosis of cancer, and this meant that despite it being a low for the patient and maybe some of the nurses, it also meant that these patients, because they were early cancers, these patients could get treatment quicker, and because it was an early cancer, the treatment was effective, and therefore the patient had a good outcome. So again, you know, with some of the lows, I think the highs really negate some of those lows, and you know, it really, the BEST3 trial was a success really because of the commitment from all the individuals who took part in it. So in conclusion, the findings from this trial has made a difference to a number of patients and has highlighted the next steps needed for successful implementation into routine clinical care. It has highlighted that we need dedicated nurse-led clinics and time to do these clinics. It has helped us to standardize the processes for clinical rollout. It has helped us also to streamline the documentation for recording of the procedure, but also providing information and enough of that information for ongoing audit. It has established the need for putting measures in place so that the nurses' competencies are maintained after training. It has also helped us to implement a train the trainer module so that nurses already trained could disseminate some of this training to other colleagues. The need for the Cytosponge Nurses Network has been a growing need that I think kind of became more evident during this trial because of the vast number of nurses we trained. And therefore we're making progress in developing a nurses network where across the UK and Scotland, so that nurses can share their experience and knowledge and offer support to their colleagues. So thank you everybody for all you've done and for making this study such a success. Each and every one of you have played a significant part in this study and in making sure that we deliver the study on time and safely. Thank you. So now we'll move on to the questions. I'll stop sharing my screen. Is everybody back?
You're back. Just realised I completely got the years wrong in my introduction. Honestly, it's too recent, this thing. It's 1718, not 1920, isn't it? Honestly. But anyway.
You want to do it again?
Just,
you want to
do you know what? Don't worry about it. Just see how many people comment on it.
Okay, so part of so it's very nice to have you all as part of this this group, because I think we have a lot to offer, and we've had a great experience delivering on this trial, and therefore I want to go back to when we first presented this trial to you and the Cytosponge device. I know it's a little while ago, but the questions I'm going to kind of put towards you are questions that's been raised by other people along the line. So it'd be nice to kind of get some feedback from you. So what was your first impression of the BEST3 trial and the use of the Cytosponge device? Who would like to take that?
Well,
Yeah, I think.
Yeah, I think our first impression was no way.
Yeah.
To be perfectly honest, I just looked at it with absolute horror, because the immediate thing that jumps into your mind is what can go wrong. I kind of didn't look at I thought the study itself was really good, but I looked at what could go wrong, and we did say at the beginning.
And I think when we went down to Cambridge for the training and we saw the Cytosponge delivered, and we were on the way back on the train, we talked about it and said, you know, you're in a hospital there, you've got everybody around you, you've got all the support if something goes wrong. We're going to be in a GP surgery in the middle of God knows where. And we were very, very anxious, I think, is a fair comment, isn't it? At the start.
Yeah. I had a completely different reaction. Now, I will say my background is intensive care, so intervention wasn't so that does make a difference, I think. But I remember the moment, almost it was discussed in the office where I was standing, and I just thought, I want a piece of this. It was even before Mary had started, and I remember one of my colleagues had a similar reaction to you, and I thought, oh, I'm relatively new, but I really want it. And I just kind of said, can I have this one? You know, because I could really see, I think, because I'd seen so many people die of esophageal cancer, and it was a long-term memory for me, even from when I was a student, the horror of it and the lovely people you lost. And I'd see that surgery and how brutal that was, and this just seemed like an ideal, I almost get emotional about it, an ideal, you know, really good way of saving more lives and getting that intervention in earlier and making a difference to people. And, you know, yeah, so that was my first reaction.
I think we saw the positives of that, but I think it was the actual delivery that frightened us till we got to know more about it.
I think I thought, oh, what a clever idea. That's what I thought. Who came up with that? What a clever idea. I'm not sure that I would be good at swallowing, because I'm not good at swallowing tablets. So I did have that thought, but I did think, oh, that is a clever idea. Yeah.
In terms of risk, the way I looked at it though early on was I had seen people have endoscopies, lots of them, on a critical care unit. I knew how brutal that was. To my mind, something that fits in a pill and is compressible is going to do so much potential less harm, you know, than anything else. You could do those all day. Every now and again, an endoscopist will perf an esophagus or do some severe damage, then you're much less likely to, with this, it's much gentler approach on people. And as a first approach, I thought it was a really good idea.
I think for us though, I think it was a bit off-putting as well when one of the GPs said, well, I wouldn't want to be the string puller. that didn't help. No. But as I say, that was right at the very, very beginning, before we'd even had any discussions. It was just flagged up to us, and have a look at this and see what you think. It just shows you how you can completely turn it around.
Change your mind.
Yeah.
And I will say, the first time I pulled the string, Irene was there with me. The first time I pulled, I thought, seriously, this hard? You know, it comes around here, and it just felt, I'm thinking, I've taken out NG tubes and done all, this just feels a bit, what's going to come with this? You know, she said, no,
Yeah.
and it's like, okay, so you had to get your head around that. So I can really see where you're coming from. It is a bit daunting, that, but
yeah. And Lydia?
Yeah, so I was impressed by how well organised it was and the excellent training that we had. I think my initial thought was, how on earth am I going to get somebody to be able to swallow that pill?
Yeah.
I knew that I would be able to, but I don't have a, particularly sort of violent gag reflex. But my colleague, Diane, who also was one of the nurses on the trial, she said I couldn't do it at all.
No,
so
me neither.
Sort of thinking, yeah, it might be a bit difficult to get people to actually swallow it. So that was my initial thought. But like you, Mary, the wow, what an amazing idea to reduce the having to do an endoscopy.
And what do you think about the swallowing? You think would put people off? Not the capsule, but would it be the capsule or the string?
No, what I found was the most irritating thing was the string. People are used to taking capsules, and the capsule is probably no bigger than a big multivitamin. But the string is weird. The string feels weird in somebody's mouth, and feels weird on the back of their tongue. So the key would be just to get it in and get it down, get it off their tongue as quick as possible, so that they, the less time they have to think about it, the better.
Yeah. I think when you swallow a pill, you know that you swallow it and it's gone, don't you? Whereas, if that pill is attached to a string and you know that you can't swallow the string down, I think that is, what I think perhaps a lot of people were concerned about. The thought of having string there and just not being able to do anything about it and still being willing to do it. It's amazing.
I think we were quite surprised, actually, the amount of patients who agreed to do it. And the consensus was that a lot of them had had endoscopies at some time in their past. And they actually said, this is a doddle compared to that. So I think that made it a lot easier for us as well, didn't it, Jill?
It did.
Yeah.
what I noticed about it was, adapting to the string. That people would think, oh, I can easily do that. So they'd look at the string and think, that's no problem. Look at the pill and think that's not a problem at all. And they'd be dismissive of the string. And I had to kind of explain, when I watch people do it, it was like, trying to wean your baby onto food, the way the tongue would make this strange movement, because none of us have any idea how to get string to go down. So you have to really reinforce, this is going to be strange, and you really need to try and bypass your tongue as much as possible. Because that string, I can only imagine. I never got to try it myself. I was really quite keen.
So just, there was another question. If you could recall one memory of your clinic, what would that be?
I can recall a lady who swallowed the capsule, had the string there. We sat on the length of time, and then she refused to open her mouth to let me pull it out. You're not taking it out. At which point I'm thinking, what do I do now? But we persuaded her, and we did take it out. So she was a character. Nikki, wasn't she? You know the lady I'm talking about.
She certainly was.
Yeah, she wouldn't open up. She wouldn't open her mouth for me to take it out. So that was my one abiding memory. But she was a one-off.
She was, definitely. And I think for the first one for us as well, she was a lady who was about, I think we were with you, Irene. She was about 82 and she was tiny, and she just swallowed it down. We sat and had a conversation, pulled it back up, and she just said, is that it?
I think she said something like, I've had babies, it couldn't be any worse than having a baby, something like that. Yeah. So I think that was the very first one I think I did with you, Irene, and that sort of made you think, it's not as bad as I thought.
And Mary?
I remember a gentleman, and how it was kind of fairly early on in the whole process, but I thought because he was a military man, so I thought, oh, he'll be easy. You know, he's been to war. This is nothing. And how wrong was I? Because I will never forget him. And he was the hardest person to, I thought he was going to go into spasm. I really thought I'm going to have to put my foot on his chest to get this out. So, yeah, bless him. I can still see his face. But it all ended happily. But yeah, you can just never assume. You just never assume, you know, this one's going to be easy, because you never know.
Yeah. Was he all right after it?
Oh yeah, he was fine. He was fine. I was sweating.
Oh, Siobhan?
Well, yeah, it's a similar one like that, but the other one that stands out is I remember we had a very anxious lady who came in with family even as well, because she needed a lot of support and she really wanted to do this. But even on the first appointment, she just wasn't. She was so nervous that I said, listen, I really need, you know, go home, have a real think about it. You're not obliged to do this or anything. I can't remember, were you with me or not, Mary? You could have been. But and we said, but she came back the next week and she really wanted to do this. And you know, and she was really keen, and you just took plenty of time. We had known she was coming, so we knew to give her plenty of time, and she actually did it. And it was that sense of pride that she felt when she went out, that I've managed to do this. It frightened me, really wanted to do this, and we were there hoping it wouldn't. I will say, she was one who had to come back for an endoscopy.
Oh dear.
You know, in the end. So hopefully it was, you know, that they found something that it was a benefit to her rather than just. But I thought, oh, it would be, you know, the one who had to still have to go further, because she was a lovely lady.
Yeah.
That's the one stands out, I suppose.
Yeah.
For me, it was, so I remember one participant who was quite a young chap. Once he'd swallowed the capsule and was waiting, I said, you know, it's up to you what you want to do. So he got out his phone and he started to play Candy Crush. For the full 5 minutes, he played Candy Crush, or we probably waited a little bit longer than that. Yeah, so that was probably my, I mean, I've got lots of memories, but that for me was particularly different thing. Yeah. So.
And I kind of presented my highs and lows, and some of it would probably be a bit similar to what you experienced. What were some of your highs and lows of the study?
I think for me, the lows were probably the fear at the beginning. But the high, the main high, I have to say, was the support that we got. And I'm not just saying that because you're sitting there, Irene. We've talked about this a lot since. And the BEST3 team were one of the most supportive study teams we've worked with. And I think that's probably why we enjoyed working on the study, because I didn't expect to enjoy working on the study when I started. But looking back, certainly I did, and I know Nikki did, thoroughly enjoy it. And that was due to the excellent support we got. That was the main high for me.
I will have to thoroughly agree with that as well. You know, it was really good, but also it was the patient response and the people who came in, the varied and different people who came in, and they had all sorts of things going on in the background, and they're still volunteering to take part in research because they're hoping it'll do. I mean, I had someone, was he 95 or 96, you know, come in to take part in research. You're just thinking, oh my goodness, that is amazing. If there was one thing, I would say maybe some of our practices struggled with the spreadsheet system and things like that in the IT. And I have some who still say, you know, just don't come near me with stuff like that. And, you know, and other people were just, it was just like, I don't know what the problem is. So that was the only thing that was a challenge for us within some practices. But yeah, no, great team to work with.
I have to say, no matter when you phoned, you know, if you were phoning for whatever reason, there was always somebody there at the end of the phone to talk to, which was very reassuring, I have to say, when you had a question or a query.
I think Beth probably got a bit fed up with my phone calls, to be quite honest. I was always phoning her. For me, so the highs were getting to work with great teams in primary care sites. I really loved watching the clinics fill up on the database. I'd look quite frequently to see how my clinics were filling up. For me, a low was the fact, so there were 3 of us nurses working on this study from our team, and I got the most low confidence results of all 3 of us. So for me, that was a real low of this study, actually getting more low confidence results than my colleagues. But apart from that, I agree, we did have fantastic support from everyone. So that was really good.
Yeah, I would just agree with all of that, and I would say the other thing was the rapport you built with the patients, because it started with the phone calls, and you felt you'd started a really good relationship then. And then when you saw them, we had one lady, I don't know whether you can remember, Jill, and she said she didn't mind if she had to come back again because she'd really enjoyed the crack. But you're right, and I think the lows for me was when they couldn't swallow it, because you kind of felt a bit of a failure yourself because you'd tried it twice and they couldn't get it down, and especially if they really wanted to do it and they were really disappointed. So I think that was probably the low for me.
And those are all valuable things. I think, I've done a number of these clinics, and there are so many experiences I can draw upon, and there are good ones, there are bad ones, but I'm thank you very much for expressing what the highs and lows of your experience with the study. Having had experience in doing these clinics, what would be your advice to another professional setting up a similar clinic?
Prepare. Spend lots of time preparing. Yeah, kind of go through scenarios that you might come across and have a process ready to deal with whatever you might come across. Yeah.
I think have some support there with you as well at first.
Yeah.
Till you get more confident, just in case something does happen. So you've got somebody there for a bit of backup. Till you get confident, because that's what we did, isn't it, Nikki, at the beginning?
Yeah. And don't go with your first impression.
Yes.
Get over your first impression, and think about how valuable this is going to be, and have that support network, because even if you've just got that one person in the room or even in a room next door, it just makes you feel more confident knowing that you've got that support network there. So yeah, I agree with Jill on that one.
I think always knowing that you have prepared for the worst if things go wrong. So it's kind of like expect the unexpected. I'd almost have pre-printed referral forms in case you had to send people off, so that you could just quickly, print something off, add in the necessary data, and have a GP back, to back you up and arrange that, so that, if things went wrong, it was very smoothly dealt with. It's having that mechanism in place early on, I think, would make it different. Yeah, but it's like,
well, that helps with your confidence as well, doesn't it? If you know exactly what to do when.
Lydia?
And I would say to make sure that you use checklists for all your equipment. So right at the beginning, to create a checklist and make sure that each clinic you do tick off everything, because there is, well, for the study, there were a lot of processes. Maybe if it wasn't as part of a study, there would be less, but you still need to make sure that you've got your equipment, and also, all the processes that you have to complete as well. Use checklists, definitely. And also, one of the things I was thinking also is about managing the expectations of the patient. So you do need to, right at the beginning, tell them that you may well gag, you might feel the string at the back of the throat. I mean, I know that's all things that we would do, but certainly if I was telling somebody that had never done a clinic before, that's probably what I would say. Yeah.
Thank you. So just moving on, there are a few more questions to go. When would you recommend the use of local anesthetic, and how would this be helpful to a patient during the test?
Not a fan of it, I have to say.
You're not, yeah.
No, I can't see. I don't think I might have used it once, maybe twice. And even then, yeah, I think we both had people who came back for a second one and they didn't have it the second time.
Right, yeah.
I think people were far more interested in having their cup of tea or coffee or whatever it was afterwards.
Yeah.
Or
Yeah,
ice
we-
cream.
Ice
We
cream,
didn't
yeah.
use it. Yeah, we didn't use it at all.
Oh,
No.
did you not? Okay.
No,
No.
I think I
we
probably
offered
used
it.
three
Yeah, we offered it.
times. Yeah.
Yeah.
3 times at the most, I would say I used it. I think, yeah, if they know that they can have it, but they can't have it until they've swallowed the capsule, then I think, you know, most people said, oh, I'll see how I feel. And then when they found that it was okay, it was tolerable, they said, oh, well, yeah, like you've said, I'd much prefer to be able to have my cup of tea or
Yeah.
Drink. Yeah.
or something. Yeah.
Yeah.
Afterwards.
Yeah, I've noticed that as well when in some of my clinics now that, you know, we're sort of rolling it out, that, you know, they really do want, they've been ill by mouth for 4 hours and therefore they'd really like to have a drink. They'd really like to have something to eat. So the chances and the thought of them having to wait another half an hour to an hour before they can have something hot then really puts them off.
I never really saw, there wasn't a huge amount of benefit because the most you can get is the top half here, where you really possibly, it's here at the most uncomfortable maybe going past, and you don't really, it's not really effective at that level for people. So I'm not too sure they felt much pain in the back of their throat by the time, because there's so much space there for it to come out at that stage and it's very quickly gone. Yeah, I think most people were quite happy. And as I say, I did have one lady who had it the first time and had it the second and said, oh yeah, I'd never, you know, she said, I didn't really notice the difference, you know, so she was quite comfortable. But she said if it, you know, to recommend not having it.
I think that the instances where I use it is where the people have very sensitive gag reflex. And so from the time the sponge goes down, that just having that string at the back of the throat just causes them to gag and cough. And I think once you're confident enough that the sponge has actually gone down, I think that does help them a little bit to put a little bit of spray. And the reason for that is because if somebody continues to gag and cough, and the chances of them coughing the sponge up is much more likely. And therefore, if they cough it up into the middle of the esophagus, it means that when you're ready to pull that out, you're not going to get a very good sample. So I think in those instances, that's when I would recommend possibly a little spray, is where that patient's got a really strong gag reflex and they're not able to tolerate that string at the back of the throat.
Yeah, it's funny because I will say that rings a bell with me, because sometimes people who gagged a lot, I'd pull it and I'd say, I don't think that's down. And I think I'd spoken to you before, it would just be at the back of the throat. Now, whether they gagged it back up or it was irritating because it never went down, because I'm sure with some of these people, they swallowed the second one and they were absolutely fine. So it's whether, you know, but actually your point is they could have retched it up too. So that's really quite interesting.
Yeah, but it's something to bear in mind, I think, you know, when you're, it may not be what the patient wants, but you might be able to assess to see whether it's right for that patient, if you know what I mean. What are the side effects of having the procedure, and how would you mitigate some of these risks? Can you remember some of the side effects? It's a while.
Sore throat was the most common thing, which lasted for a couple of hours to maybe the following day or something like that. But, that was the most common thing. And we just warned them about that. To expect it, and if they wanted to take a few analgesia, that was fine. Or we used to say have a cold drink. Ice lolly used to go down as a quite well, yeah. But I mean, generally very well tolerated, I think.
Anyone else?
There was always the risk of bleeding, wasn't there? I think of all the people that I phoned after having had the procedure, I think one had bleeding, but not a lot, had just coughed up some blood. I think it's just, again, managing their expectations, just letting them know that they may well do it. Obviously, if it's a lot, then they would need to contact their GP, or, you know, if it's really excessive, to follow emergency procedures. But yeah, just to let them know that they may well cough up some blood.
Yeah.
A couple
And
of mine
stop
just had
to
some
worry about. Sorry.
nothing. No, it's fine. Increased heartburn, I suppose, was maybe the one, but they normally did have some medication that just sometimes just some of their liquid antacids would be quite good for that, to kind of help to relieve that. Something over the counter would relieve that for them, probably on top of the omeprazole, which they all were pretty much on. Yeah.
Okay. Anybody else need to add anything else to that? How would you deal with the detachment, or if somebody had significant esophageal spasm?
Thankfully, it never happened to me. But I think knowing that you had a GP in the building for a start, somebody that was close by that you could ask for help, knowing that you had the endoscopy unit were aware that you were doing a clinic and hopefully you wouldn't need to contact them, but knowing you had that backup, I think was always reassuring for us and for the, I don't know if it was reassuring for the patients or scary for the patients really, to tell them that you know, if something happens, you would have to go straight for an endoscopy. Because I think most people assumed you would let nature take its course and it would come out the other end. And I think it was when you said that to people, actually, no, you can't do that. We'll have to get it back up. I think that was possibly the bit that frightened people a little bit. But I think it was just reassuring people that there was expert help on hand if needed.
Yeah.
We did have a detachment in our area that was over at the Norfolk team, dealt with that. And they dealt they said it was very streamlined because you have the GPs there who know you're doing it. They just did the referral. We had the secondary care site on standby. And actually the patient was really impressed by how it was handled. And that's why I think it's important to people who are setting up clinics that they have these things streamlined. So there's an obvious, this is what you do in that for the detachments or the bleeds. In case of a spasm, I think it's very much a case of settling people down, just get them relaxed and give them some time, because the spasm should settle. And it's something you probably, I'm sure most GP practices are used to dealing with, kind of like panic attacks and helping people to relax. It's kind of part of the day, and hopefully that should come out by itself, or else it would be a referral if you know, 20 minutes of just relaxing somewhere didn't help. I don't know, Irene will probably have a better, you've dealt with that. I know you told us a story about a consultant actually before we started, who his esophagus went into spasm, and he went around for a couple of hours with the string hanging around his mouth, looking at notes and doing all sorts with the string hanging out of his mouth, and just until it sorted enough for him to get it up, which I thought was a great story actually.
Yes. Yeah, and I mean, you know, on the BEST3 trial, we had one detachment, and that was with over 16,000 odd patients, you know, 1,600 odd patients. So that's pretty good going, isn't it? I think, you know, from, you know, so it's, I think, you know, I can only recall from the Norfolk team, that was pretty straightforward, and the way they arranged it was pretty slick. And everything. And I happened to be in Norfolk at the time when it happened, so I was just around the corner from them. So it was great, and you know, we had a chance to debrief. And I think sometimes that, you know, having encountered that yourself, you do from a nurse's point of view, because you know that's the unlikelihood of it happening is such a rare thing that, you know, when it does happen, you need to kind of talk about it, you know, what you know. And it was nice that they could then come and meet me at one of the GP practices, and we had a little bit of a debrief. And, you know, it was fine then to kind of talk through, you know, whether they could have done anything different. And in some of these cases, there's nothing else. You've done everything you can, and it's just one of those things, you know. So I think it was pretty good that we only had one detachment. I think that just shows the robustness of the actual device, and you know, and really shows that the device is pretty safe, you know, to be used in individuals. So yeah. Did anybody else have any spasms while they were? No. Yeah, I remember there was another patient recently, and one of the ladies said to me, she just, the patient had the spasm, and she said, oh, all I did was I got them to swallow it back down and just got them really, you know, sort of more relaxed. And then within a few minutes, she was able to retrieve it. So I think that's key. I think, Siobhan, you touched about that, is that you give the patient sufficient time. Sometimes patients are so anxious. They're so sort of, you know, anxious about this thing being pulled back up, that all the muscles around their neck just tighten up even before you even touch the string. So sometimes it's if you can implement sort of different ways of making that patient relax, then that probably will go a long way as well. We're nearly there, girls. So the patient has 7.5 minutes for a capsule. I think when we did the BEST3 trial, it was 5 minutes, so it wasn't too bad. And you could kind of get on and do some of your paperwork, etc., or talk to the patient if the patient felt inclined they wanted to continue talking. But now it's 7.5 minutes. It's a little bit longer. What would you recommend the nurse or healthcare professional do in that time?
Talk to them. We used to sit and natter.
Yeah.
We didn't do the paperwork or anything. We just used to sit and chat about holidays, children, grandchildren, the weather, anything to sort of distract people. And I think most people seem to quite like that, to take the mind off the fact they've got this bit of string dangling there like a tea bag. We used to try and avoid actually doing anything other than sit and natter to them during that time, and that seemed to work, didn't it?
Yeah, I think distracting is the best way if you can.
Yeah.
Most people are good at, if you distract them. I suppose the only other thing is that some people might find it more relaxing to sit there with their eyes closed and go somewhere else. So just kind of figure out which side of the fence your patient falls on.
Yeah, we did. I think we did have a couple, I have to say, the men who said, don't talk to me. Just let me sit here, and I don't want to, you can talk to me, but don't ask me questions that I need to respond to. I just want to sit here. And I have to say, it was the men. Is that very sexist? Can that bit be cut out?
Yeah, I mean, I think it depends on, so I always used to say to them, do you want me to talk to you, or do you want to be quiet, or do you want to do something of your own? So often they would have brought a book or a magazine, or like this chap that played on his phone. Obviously, if they wanted to talk to me, then that was fine. I did spend the time, though, writing out labels and all sorts of, you know, filling out documents and things, just so I had everything done and could clear everything away before the next participant came in. But yeah, no, I found it really varies on according to what they wanted.
Yeah.
I mean, going forward, I think, you know, for people who it's going to be practice nurses probably doing it on a day-to-day basis, they'll know their patients, they'll know their individual quirks and things. I mean, some people, they might use it as time to catch up on things, making sure they've got the right details on the notes if they want to talk to them, or do the other things that need to be got on with. But it's a real time to even talk about their health and how they are in themselves. It's a quick, you know, you could do so many quick assessments in that time, along with other things for them, that it can be an opportunity. 7.5 minutes is quite a time, really. But it is very much up to the individual person, isn't it, and what they're comfortable in. Nobody really knows how they're actually going to be for those few minutes, you know, how you're going to actually react to the string being there all the time as well. So just keeping an eye on them anyway.
Yeah. Great. So what are some handy tips for good swallowing technique, and what other tips would you recommend to other colleagues? What worked for you?
To swallow, I would say have 2 glasses of water ready.
Okay.
To hand. Try and, basically the key is to get it off the back of their throat as quickly as possible. So to explain to them clearly and nearly try and get them to visualize themselves that they need to wash this off the back of their throat. And to do that, they can't sip the water. they need to take huge, big gulps of water and basically visualize washing it off. So we used to get them to finish nearly 1 glass of water, you know, neck it if they could. And so gulp, 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 you know, don't stop, don't take 1 gulp and stop. You must try and keep going and basically wash it all the way down into the stomach. And then we would have a check and make sure that, you know, there was no string or anything hanging around the back. But that seemed to work for the majority of them, I would say. Siobhan, would you?
No, it did. It worked very well to, yeah, if you got them to just, as I say, put the first one down, neck it really, really quickly. That worked. Making sure the string was well bundled up together and they put it as far back. I found that they were often more successful. They put it further back than I would. So letting them put it right back, and I'd say over the hill of the tongue, just to kind of say, if you can do that and then get that down, it just makes it a straightforward trip down, and that used to make the difference. And then if there was lots of string around, we might help with poking that back for the next one and do gulps. But you used to always despair, no matter how many times you tell people. Every now and again you'd have somebody like they were just having a little taste of the first, you know, the first thing of wine, and you're just thinking, this is just going to get it sticky, and it ain't.
Who does that?
Yeah.
You just think, sip, not cut the mustard.
I think we found the opposite. We found it easier for us to put it in, and most patients preferred that than them putting it in themselves. There was 1 or 2 that did it themselves, but on the whole, most patients preferred that we actually put it into the back, because sometimes it was too fiddly for them to get hold of anyway, but they just would say, no, just go on, just do it.
Oh, that's interesting. So I would give them the choice, and most people chose to do it themselves.
Yeah.
My little phrase was similar to over the hill, but I would say over the crest of your tongue, because people know what that means. So it's like hill, isn't it? Over the crest of your tongue, and that seemed to strike a chord with people. They, you know, when you say things. So if you just say to the back of your tongue, you know, that doesn't really mean anything, because it's different things for different people. But if you actually know that it's got to almost disappear, then that made it easier. And big gulps of water, definitely at the beginning.
I found they could estimate their own gag reflex better. And so I didn't want to be pushing it too far back, I suppose. If they were happy to do it, then I'd watch them. I think, wow, that was further than I put it. And it just meant that, you know, you reduced your low confidence rates, hopefully, a little bit anyway.
Jill, anything to add?
The only thing I would say as well is we found it helpful to practice the string beforehand, because you don't want to look as though you're fumbling in front of the patient. So I remember we sat in the office with one of the practice ones, and people were walking past thinking, what on earth are you doing? And we're practicing folding the string to get it all bundled ready. So your string technique, I think, is fairly important as well.
Yeah, we spent a lot of time trying to figure out a way to do that and how to, there must be another way of doing this. We didn't find another one though, Irene.
There's still always, you're still going to drop it every now and again. You just think, I'm sorry, I need to redo this, and they just, you know.
Well, now we've got a different retainer, so you can actually sort of use the retainer to help you. So
excellent.
It's a little bit different, but it does help some of the nurses now going forward, that they could potentially use that to just get it nicely wound round, you know.
I have to say, so sometimes I would just put around my gloved fingers, I would wrap the string around and then take it all off in one bunch, like that.
I think the only thing I'm quite conscious is that when they do that is that they don't overlap the string, because the potential of it kind of knotting them. Yeah. And I've had some incidences where they've kind of overlapped it and swallowed it.
Right. Yeah, I can see that could potentially happen. Yeah.
But you know, the patient got it down, and you think, oh yeah, well they've got it down, and then when you pull it up, there's a big knot in the string, and then you realize, oh, that probably didn't go all the way down. So you know, it's just, you know, I suppose, you know, with this is you have to, when you're doing this technique, you have to find what works for you.
Yeah.
And there's various ways of bunching that string, but I agree with Jill. It needs to be done properly, and it's best to practice doing that, because if you get it right and you, whether the patient takes it from you or whether you put it behind the throat or behind the crest of the mouth or the tongue, then you know it's important. That first swallow is so important to getting that pill down. Just a little bit about on the parts of results, and I think for nurses out there, what do you think you can tell them low confidence result mean, and how would you overcome some of these this result? What are some of the sort of scenarios that you could remember that where you got low confidence results?
Well, for me, so I don't remember in my training being told to position the string into the center of the tongue to retrieve it. And then I was chatting, I did get quite a lot of low confidence results, and I was chatting with one of my colleagues and she happened to mention it. So I said, oh, okay, I don't remember that part. And so I did start doing that, and actually it did improve my, definitely improved the confidence levels of the results that I got. So, yeah, so that was good. So making sure that the string is sort of pushed back into the center to retrieve it. Yeah.
Anybody else?
So to my mind, a low confidence result just means that it didn't go down the entire, it didn't go into the stomach. We don't have stomach cells, so it's not something for them to be concerned about. But I did notice that some of them were quite a few, quite a few of the ones that I had were ones that they had other issues potentially with swallow. They had other maybe muscular weakness issues, muscular dystrophy, and early stages of things that maybe would have affected their swallow. So it's really important to do a good patient assessment, that it may not work for all your patients and that it may not even be appropriate for you to put them through that when it's not going to succeed. So it's knowing that they have no problem, which we do to a degree, because we did ask them, and these people would have no problem swallowing their pills, but it just, I think with the string was the extra complication. But the key, I think, for me is the good swallow technique. An early good strong swallow is, if the sponge is as far back as possible, that worked really well.
Good. And I'll just move on quickly. So how was a positive result received by your patients? Can you remember any of your patients getting positive results, and what did this mean to the patient? Do you recall any of those incidences?
Well, I think we discussed it with them, when we were doing the consent. So the options of what would happen is that it would be negative, or it could be positive, or it could be indeterminate. Yeah. So those were the kind of options that would follow from the procedure. So they knew that if they had a positive result, then that would mean that they would end up having to have an endoscopy to confirm. But you also kind of had to explain to them that this doesn't mean, anything dreadful might be happening, but they do need to go further and just confirm what is going on.
I myself was never involved in giving the diagnosis back. It was always given by a GP, and then the study team and yourself dealt with the follow-on. So I never really had experience of that. So
no, myself.
Same
yeah,
same we didn't either.
Okay. And what follow-up mechanisms would you advise to have in place?
Well, I think definitely to have regular training updates would be very beneficial, because it's just useful. I mean, if I was asked to do a clinic now, I would definitely want to do a training update just to re-hone some skills.
Yeah.
I read that question slightly differently in terms of, is that follow-up mechanisms for clinics that you're running? So for patients after that, my only thought on that was, I really do think it was really valuable for patients to know that they could ring, mostly you, Irene, you know, for the following week if they could. And I just think if they had a named person that they could ring at the practice, that even if they weren't able to answer, they would ring them back or get back in contact, you know, about that, so that they could talk about their worries, you know, for the next week or so, if they had any concerns on that aspect. I mean, nighttime calls obviously can't be dealt with that way, but they can go through the usual services for that. But I think it's really nice for them to feel, if I feel anything's different, I have somebody I can directly talk to.
Yeah.
And do you think this, do you think the 7-day phone call kind of helped with that, you know, because you did that following the procedure, and that kind of alleviated some of their anxieties, do you think?
I think knowing you were there meant a lot to them, actually, you know. And we'd say you're there day or night, and they felt really good. And what I really liked then was they heard, I don't know, did you get many calls at all? I don't think you got many at all. So I think that was just being there is enough, and putting that in place makes a real difference to people.
I'll tell you what else I liked was the actual feedback on the BEST3 sort of database from the patients. That was, but I mean, I know that's different, but actually, you know, that was really helpful to me to see that actually most people found it was very tolerable. You know, they'd had a good experience, so that was really encouraging. Definitely. And
then from a nurse's point of view, that kind of either boosts your confidence, didn't it? It kind of gave you a bit of reassurance you were doing something right.
Yeah.
Mostly the chatting, I think, for myself and Mary.
Yeah. I think early on, sort of into the study, when we'd sort of a few patients down the line, you really started to enjoy it, started to enjoy it. And as I say, I think the rapport with the patient as well, and listening to them, the reasons why they wanted to take part and why they're happy to have it done. And I think most people, I think maybe we had one or two that after the full explanation backed out and said, no, I don't want to do it. On the whole, most patients went ahead and had it done. And I think building up that rapport and actually really enjoy doing it, and feeling that, wow, I'm contributing to something that's going to be really, really valuable in the future.
I'm really sorry, I've got to go. I'm sorry, I've got somewhere to be at 4 o'clock. So
okay. Thank you, Lydia.
Okay, thanks.
Nice to meet you.
Thank you all.
Nice to meet you.
Bye-bye. Bye. Hang on. There we go.
And anything else to add? Yeah. Well, it's been great having you all on the panel. I think it's been great discussions. I think you've highlighted some of the things we need to take forward. And some of the things, you've identified some of the things that we probably still need to address. But, you know, I think having a network of nurses, I think going forward, will provide that platform for nurses then taking this on in a clinical setting. And thank you all very much. And thank you for all your contributions to BEST3 Trial. It's been a pleasure working with all of you.
Likewise.
Thank you.
It's brought back lots of nice memories.
You did, yeah.
I did. Yeah.
Do you have any idea on timeline when it's going to be rolled out?
Yeah, so we've worked with the Scottish Government at the moment, and they're actually rolling it out in clinical practice out in Scotland at the moment. And I think it being a pandemic has kind of fueled this a little bit in getting it into clinical practice. So they're using so we've done a lot of the training up in Scotland, and they're now using it as a device for both patients with dyspepsia symptoms and reflux symptoms, but also patients who are on Barrett surveillance. And we're now working with NHS England to kind of roll this out to centres around the UK, or within England, I suppose, not the whole of the UK just yet, getting these set up in in secondary care practice, secondary care units. The other thing is we are looking into setting up a mobile unit where we can probably roll out the site one in.
Did you not wait until Mary was gone? She won't be able to come.
Jealous.
You got one.
Very jealous.
So that's one of the current things we're working on in setting up this mobile unit where we could potentially reach individuals who have got problems probably getting to their GP practices or feel really intimidated by going to a GP practice but have symptoms. And we thought that probably making it easier for individuals where it's you're offering a service, but it's probably doesn't impact on them going to a GP practice where at the moment they've got limited access, etc. Might make it easier for some of these patients for the uptake of the cytosponge in these areas. So yeah, we're working on a multitude of ways and things, and really making sure that we can bring the cytosponge to those who actually need it. So yeah, and this could have not been done with all your contribution and your hard work in making sure we fulfilled the requirements of the BEST3 trial.
We were led by the best.
Absolutely.
Yeah.
Thank you all very much, and thank you again for giving up your time to be part of this this presentation and for your valuable input.
Pleasure.
Thank you. Pleasure.
Take
Okay.
care.
Bye-bye.
Bye.
Caitlin, do you want to join us again? Keyboard.
Sorry, screens. That's great. No, thank you so much. That was really good. A lot of content, but we'll definitely we can edit it where there were mistakes or.
Yeah, you need to take my sexist bit out.
Oh, right.
I know there was some bits where I got, when you're on a flow and then you kind of lose